Today we are going to talk about systemic lupus erythematosus, or SLE. This is an inflammatory autoimmune disorder that can affect nearly every organ system in the body. While relatively rare, it carries significant impact for the people who live with it. The overall incidence is estimated to be between 2 and 8 cases per 100,000 people. Women are affected far more often than men, at a ratio of 4 to 12 to 1, and it is seen more frequently in African American, Hispanic, Asian, and Native American populations compared with white Americans. In addition to the classic systemic form, there are other types, such as subacute cutaneous lupus, discoid lupus, and drug-induced lupus. The exact cause is not known, but lupus begins when the immune system mistakenly identifies components of the cell nucleus as foreign. The body produces antibodies against these nuclear antigens. B cells overproduce antibodies with the help of cytokines such as BLyS, which is overexpressed in lupus. These antibodies combine with antigens to form immune complexes, which get trapped in small capillaries of visceral organs and also directly damage host cells. These processes together drive the disease. Several factors are believed to contribute. Genetics play a role, but most cases are sporadic rather than inherited. Hormones, especially estrogen, are thought to explain why lupus is more common in women. Environmental triggers, such as cigarette smoke, ultraviolet light, certain medications, viral infections, stress, surgery, pregnancy, and even occupational exposures like silica dust may set off the disease in people who are predisposed. SLE is systemic, meaning it can touch almost any organ. The disease follows a pattern of chronic low activity with occasional acute flares. Common symptoms include fever, fatigue, skin rashes, and joint pain or swelling. The skin is affected in up to 85% of patients, with rashes that may worsen with sun exposure or fluorescent light. Discoid rashes can scar and cause pigmentation changes. Oral ulcers may appear on the buccal mucosa or palate, often during flares. Patients may also develop alopecia, Raynaud's phenomenon, or small hemorrhages in the nails. Musculoskeletal involvement is very common. More than 90% of patients experience joint pain, swelling, and stiffness that often resembles rheumatoid arthritis. Morning stiffness is frequent. The cardiovascular system is also at risk. Pericarditis is the most common cardiac manifestation, often presenting as substernal chest pain made worse by movement or inspiration. Other possibilities include myocarditis, hypertension, arrhythmias, and valvular disease. The kidneys are another major target. Lupus nephritis develops when immune complexes damage the nephrons. Creatinine and urinalysis are used to screen for renal involvement. Hypertension may develop as a result. Early detection is crucial to prevent permanent renal damage. Neurologic involvement is broad and can range from subtle cognitive changes to seizures, psychosis, neuropathies, or even strokes. Patients and families may first notice changes in mood, memory, or behavior. Diagnosis of lupus is based on history, physical exam, and lab testing. The skin should be examined for rashes, and the patient asked about photosensitivity. The scalp is checked for hair loss, and the mouth for ulcers. Cardiovascular and respiratory systems are assessed for pericardial rubs, abnormal lung sounds, or effusions. Joints are examined for swelling, warmth, and tenderness. Neurologic status is evaluated with attention to depression, psychosis, or seizure activity. Laboratory findings are critical. Anti-nuclear antibody, or ANA, is positive in more than 95% of patients. Anti-DNA and anti-dsDNA antibodies are more specific and help distinguish lupus from drug-induced disease. Anti-SM antibody is also highly specific. The complete blood count may reveal anemia, low platelets, or low white blood cell counts. Treatment has advanced greatly in recent years. The goal is to prevent organ damage, reduce disease activity, and minimize disability. In the acute setting, the focus is on controlling flares. Long-term, the focus shifts to monitoring and preventing progression. Several categories of medications are used. Monoclonal antibodies such as belimumab and rituximab directly target immune system pathways. Belimumab blocks BLyS, preventing B cells from overproducing antibodies. Corticosteroids are used in varying doses, from topical creams for skin disease to high-dose intravenous therapy for severe flares. They work quickly but carry risks such as osteoporosis and fractures. Anti-malarial drugs such as hydroxychloroquine are effective for skin and joint symptoms and mild systemic disease. NSAIDs can help with minor musculoskeletal complaints, though they are usually adjuncts. Immunosuppressants such as cyclophosphamide, azathioprine, mycophenolate, and methotrexate are reserved for serious organ involvement, especially lupus nephritis. These are contraindicated in pregnancy. Nursing management is multifaceted. Patients with lupus often face fatigue, skin breakdown, changes in appearance, and a need for complex self-management. Education is key, and support groups can be very helpful. Because sun exposure can trigger flares, patients should be taught to avoid ultraviolet light or use sunscreen and protective clothing. Nurses also help patients cope with body image changes and the unpredictable nature of the disease. Because lupus can affect multiple organ systems, regular screening is vital. Cardiovascular risk is elevated, so blood pressure and lipid monitoring are important. Dietary consultation may be needed to address nutrition and cardiovascular risk. Patients should also be counseled about smoking cessation, including avoidance of electronic nicotine devices, as smoking worsens cardiovascular, renal, and skin complications, and interferes with medications such as hydroxychloroquine. Medication education is essential. Patients need to understand their regimen, the importance of adherence, and the side effects to watch for. Because immunosuppressive therapy increases infection risk, patients must be taught to recognize early signs of infection. Bone health is another important focus, as long-term steroid use can lead to osteoporosis. Baseline and periodic bone mineral density testing, calcium and vitamin D supplementation, and weight-bearing exercise are recommended. Ultimately, the nurse's role extends beyond the hospital. Patients with lupus need guidance, monitoring, and encouragement to manage a disease that is unpredictable and often lifelong. Sensitivity to their physical and emotional needs, along with practical education and support, makes a tremendous difference in their quality of life.